Thanks for the surprising opportunity to present. Let's see here if I can figure out all the stuff. Well, when you read the NLST, the National Lung Screening Trial, closely, the third limitation that they confessed to was we don't know if these results can be replicated in non-expert centers, which the NLST centers felt that they represented. And so what we wanted to do was look at our lung cancer screening in a non-university system. And so we started our lung cancer screening program in November of 2013. And so we had about 3.5 years of experience to look at. So in the Portland service area, which is the Providence Health System parlance for where I operate, we actually had 10 imaging centers that were combined into a single program. So 7 hospitals, 5 of them were community hospitals, 2 of them were tertiary care centers. That's where the Multidisciplinary Thoracic Disease Conference happens, is at the tertiary care centers. And 3 freestanding imaging centers. And the patients were referred by primary care, and lung cancer screening was carried out using the Center for Medicare and Medicaid Services NLST modified eligibility criteria. And shared decision-making initially was carried out by our team. We actually proposed it go to the primary care physicians. They were reluctant at first, but then in 2015 they wanted it back, which we were glad to give it back to them, actually. And then we had radiologists who were thoracic radiologists who were reading all the screens, and if you were a lung RADS 4, then you were presented to the multidisciplinary team to generate management recommendations. And we had a coordinator who's been a one-woman show that kind of recorded all the images and all the procedures and the pathologies and all the downstream clinical activity. And this came from November 2013 to May of 2017. So this stuff is about a year old. We had about 3,000 patients referred, and about a third of them either turned out to be ineligible or declined once they went through the shared decision-making process. So we screened about 2,000 of them, and you can see that using the eligibility criteria, that unlike the NLST where you had 3 imaging episodes, there's no interior imaging episodes. Depends on when you come in your age from 55 to 78. So you can end up with a bunch of scans. So it's nearly 3,000 scans of these 2,000 patients that we're able to evaluate. And we didn't start keeping track of Multidisciplinary Thoracic Disease Conference presentations until 2015. And you can see that of the minority actually have lung RADS 4. So lung RADS 1 is negative, 2 is benign, 3 is probably benign, and 4 is suspicious. So 4 generates additional clinical activity that's not compliant with just regular lung cancer screening. So, and you can see here that with what we've had for the past couple of years, our Multidisciplinary Thoracic Disease Conference between the 2 hospitals historically has presented between 600 and 800 patients a year. We're now, for the last 3 years, at about 900 patients. So it turns out about 100 patients a year are being presented at the multidisciplinary conference that are because of lung cancer screening vetting. And we had 46 lung cancers that were found, 2.3% lung cancer discovery rate, so that's as opposed to the NLST, which was 3.6. And you can see of the lung cancers, 67% of them were stage 1 or stage 2. And if you look at just non-small cell, then actually 77% of them were stage 1 or stage 2. As you see, we had a small number of small cells that were found, and then a small number of other cancers that were discovered that generated clinical activity downstream. Just like in the NLST, the most common additional procedure that happened to you after a scan that was suspicious is that you got additional imaging. In the NLST, it was about 14%. In the VA study published in January 2017, it was about 14%. And you can see, just like in the NLST, the most common thing is to go, instead of getting a to get a diagnostic CT scan, but all kind of other things are represented in here for a total of 483 additional studies. Of the procedures, most of them were minor procedures, so about 3.5% of patients got invasive procedures. And you can see here the procedures are typically the diagnostic ones I put on the top here are bronchoscopies or image-guided biopsies. And when you look at the major procedures, and I define major procedures as anything that got general anesthesia, and so you can see thoracoscopic lobectomy, segmentectomy, pneumonectomy, wedge resection, and then a smaller number of other cases, non-thoracic cases. And our adverse events were we had 1 death in a lobectomy patient who was kind of high risk, unrecognized. He'd had a previous head and neck cancer, treated, and his swallowing mechanism was pouring it up, dying of aspiration pneumonia complications. Conversion to thoracotomy, 1 patient. Re-op for bleeding, 1 patient. ICU admission after a laparoscopic adrenalectomy. You can debate whether this is actually really a complication, but nonetheless, that wasn't planned, so we called it as such. 4 pneumothoraces, and then 4 pneumothoraces that required a chest tube. So about 11% of all procedures actually had a complication. If you look at the total cohort, it was about 0.5% of all the screened patients with a surgical mortality of 2%. So if you look at the NLST itself, actually, published in 2011, if you look at the surgical cohort, the death within 60 days is in the CT arm was 1%, or in the X-ray, so it's 1 to 2% is the surgical mortality. And if you look at it, the procedures, all the things that could happen to you from nothing to a needle biopsy to a bronchoscopy to surgery, you can see that the complication of at least one complication ranged from around 9% up to a high of 32%, with an overall total of about 28% of the patients who had lung cancer diagnosed. If you didn't have lung cancer diagnosed, those numbers were about half. But interestingly, no invasive procedure still has, this is a cohort at risk, in other words. 16% had complications. And so our conclusion is that if you really get very organized, you can end up with the same results as the NLST, that you can find lung cancers, you can treat them, and that you can do it with low morbidity and mortality. Thanks.